Hey folks. All right, so I don't know if that recorded a long moment of pause there for a second when I first got started, but this is your lesson in lieu of class for Thursday. I have posted to Blackboard a copy of my lecture notes for that day so that you can follow along with the terminology that I'm using here. Since I don't have a whiteboard to work with at the moment, I'm recording from my computer at home. I would just recommend you print out or have on your screen a copy of the lecture notes so that as I go along here, you can keep up with the terminology I'm using, make sure that you're getting the words spelled properly, all that sort of thing. This is picking up where we left off in class the other day. For anyone who was not in class on Tuesday, we started talking about specific immunity. We took a look at what an antigen is and its role in the immune response. We talked about the self versus non-self response. We discussed the training of lymphocytes, of B cells and T cells in preparation for specific immunity. And we talked about the mechanisms of cellular immunity. So we're picking up where we left off with that to end our look at the immune system here. Now that we've dealt with cellular immunity, that's what your body is going to use whenever we're combating cellular threats. This is what you're going to use whenever you're dealing with bacteria, when you're dealing with cancer cells, when you're dealing with viral host cells, cellular agents that are setting off an immune response. But not everything that's a threat to us is going to be cellular in nature. So we also have a different way of approaching this called humoral immunity. Now, humoral immunity is going to be mediated by B cells rather than by T cells. This is a mechanism by which we are fighting off non-cellular threats. Humoral immunity is basically acting to work against viruses, against toxins, against all manner of non-living particles or molecules that are going to be a threat to our well-being. Now, the key to humoral immunity is to understand that it's being mediated by proteins called antibodies. And we're going to talk a bit more as we go here about what an antibody is, but that in humoral immunity, we're approaching things a little differently than we did in cellular immunity. In cellular immunity, we had T cells directly going after the enemy pathogen, binding onto it, destroying it, moving on. In humoral immunity, rather what we're going to be doing is finding a way to generate antibodies against the threat. Our B cells are not directly attacking a virus or a poison or any other sort of molecular pathogen. Rather, the B cells are going to be manufacturing antibodies, which will then, in turn, act against those threats. The antibody, I should point out also, is not directly destroying the threats. What you want to be thinking of here in terms of what antibodies do is that they identify pathogens and, you might say, tag them for destruction, that they neutralize them, they render them harmless, and then make it easier for other biomechanisms to kick in and destroy them. Now, first step of this, the basic 3 steps of humoral immunity are the same as the basic 3 steps of cellular immunity. Step 1, recognition stage. This does not begin particularly differently than anything else that we have seen. This is going to happen whenever an antigen binds on to a receptor found on an APC. That is an antigen presenting cell. Now, this is where we have one big difference. I told you earlier today that T cells are going to not act as APCs. B cells, which are the agents of humoral immunity, can in fact act as APCs. So we're going to have a situation where a non-cellular antigen binds onto an APC. Typically, that means a B cell. Whenever it does that, we're going to find the B cell is going to take in the antigen, absorb it through receptor-mediated endocytosis, if you remember that term from Bio 1. The B cell will digest the antigen, whether that antigen is a virus, whether that antigen is a toxin, whatever it is. And it will display epitopes, fragments of it, on its surface. In that regard, we're not doing anything particularly different than what we saw during our cellular immunity. Now, one of the cells that we saw at work in cellular immunity is actually going to help out in humoral immunity as well. Once the B cell has actually displayed epitopes, Th cells, helper T cells that we mentioned earlier today, they are going to bind onto that B cell. Hang on a second, folks. Okay, sorry about the pause there. My cat has been kind of hovering at the edge of the periphery here, and I was waiting to see if she was going to jump in front of the screen. But anyhow, though, so what we got here is our B cell has identified the threat. It's digested the antigen in question. It's displayed epitopes on its surface. Th cells are going to come along. They're going to bind on to that B cell, specifically the MHCs that we talked about earlier, are going to bind on there. The action of the Th cell binding onto the B cell is going to cause it to begin a process of rapid mitosis, which we call clonal selection, or sometimes positive selection. We're going to make lots and lots of copies of that B cell, which now recognize that antigen and know what to do about it. Now, most of those B cell copies that we are going to make are going to transform into what are called plasma cells. And the plasma cells are going to be the primary cellular agents of humoral immunity. Plasma cells will then migrate away from wherever they're produced. They'll take up residence mostly in the bone marrow. And some of them are going to go to lymph nodes as well. Once the plasma cell has gotten to wherever it needs to go, it's going to begin rapidly producing antibodies. It's going to begin manufacturing large numbers of antibodies against whatever pathogen we were taking a look at. It's a very rapid process. Your average plasma cell is going to make antibody molecules at a rate of approximately 2,000 antibody molecules per second. They're going to keep that going for 4 to 5 days, after which the plasma cell's resources will be exhausted and it will die. In the meantime, the Th cells are going to continue to stimulate mitosis in the existing B cells. Not every B cell becomes a plasma cell. The Th cells are going to continue to stimulate those B cells to divide, making more plasma cells for as long as the pathogen remains a threat. So that's been our recognition stage. So we had a B cell identify the pathogen, ingest it, break it down, display epitopes on its surface. Th cell comes along, binds to the B cell, activates it. B cell undergoes positive selection, makes lots and lots of copies. Most of them are going to become plasma cells, which will then set about the hard work of making the antibody against that pathogen. So that's step one, that's recognition. Step two of humoral immunity, same as what we saw earlier today with cellular immunity, is the attack stage. Now, attacking is going to work a little differently here. We saw that with cellular immunity, the T cell went after the pathogen directly, bound onto it, destroyed the pathogenic cell. Here, we're going to be working indirectly. We're going to be working not with cells going after the pathogen. We're going to be working through antibodies. Now, I've mentioned antibodies several times. Let's talk about them a little bit more for a minute. Antibodies are a category of protein. Those of you who remember your Bio 1 might recall defense proteins, a major category of protein produced by the immune system. If you think back to our lesson on blood, antibodies are an example of a gamma globulin. They're one of the many kinds of globulin proteins found in your blood plasma. They're gamma globulins. Now, these antibodies are going to be the agents that will actually go after the pathogen. The first thing we have to do for humoral immunity to work is that we have to make an antibody that is correct, that your cells have to manufacture an antibody that is able to defeat the pathogen. This, in a lot of ways, is the tricky part, that our plasma cells are going to go through a sort of trial and error process, whereby they're going to endeavor to build a protein that matches the shape of the pathogen. This is the period of time during which you're kind of in an arms race with whichever pathogen is afflicting you. Your body is trying to come up with an antibody against the pathogen before the pathogen can do irreparable harm to you. And most of the time we can do that. The overwhelming majority of pathogens your body confronts, it's going to be able to find a way to fight them. But in the meantime, while it's doing that, you are suffering from whatever the effects of that pathogen would be, the toxin, the virus, whatever, while your immune system tries to work up a defense. There is no one length of time this takes. Some pathogens are quite simply more difficult to build an antibody against than others. And we're not going to get into the virology here of why certain viruses are harder to fight than others, or why certain toxins are harder to fight than others. Suffice to say that some pathogens are easily defeated, some are not. And that really it comes down to how quickly your plasma cells can come up with the right antibody. Now that said, we have an amazing ability to produce antibodies. By some estimates, the human body is able to generate between 10 billion and 1 trillion different possible antibodies. This is possible because of two features of the genetic structures that lead to antibodies. The genes responsible for building antibodies exhibit two features we don't find in any other genes in the body. Firstly, a feature called somatic hypermutation. What that means is that the genes that produce antibodies mutate at a much more rapid rate than other genes do. And that's actually good, because that means that within our plasma cells, those genes are changing rapidly, and that allows the plasma cell to try out new possible ways of building an antibody, which might or might not be effective against a given virus or given pathogen. The other feature that they exhibit is pardon me, a feature called somatic recombination. And what that means is that fragments of the gene that are responsible for building that antibody can shuffle around. The gene fragments themselves can change positions within the DNA. They can recombine in a wide variety of different ways. It's sort of like having a pile of Lego bricks that you can take apart and reassemble into a variety of different shapes. By having the ability to shift around the structure of these genes, those genes are able to produce a wider variety of proteins, and therefore to make a wider variety of possible antibodies. So once the pathogen has been recognized and identified, our plasma cells are going to go to work trying to build an antibody against it. Once they have successfully created an antibody, and let's just assume for the sake of argument they have done that. They don't always do that. People die from viruses. You die from toxins. And if you die from a pathogen that's working on humoral immunity, what that basically means is that your B cells, were not able to come up with an antibody against that pathogen fast enough. They were not able to work up a defense against it. And that's the cases in which, we succumb to the virus, or we succumb to the poison, or whatever else. But let's assume for the sake of argument that you haven't done that. Let's assume that your body has worked up an appropriate antibody against the threats. What's going to happen now is those antibodies are going to go after whatever the pathogenic molecule is. Now, antibodies don't destroy the pathogen in the way that T cells destroy the pathogenic bacteria. Rather, antibodies are going to defeat molecular pathogens in one of four basic ways. Firstly, we're going to have a process called simply neutralization. In neutralization, what's going to happen is that the antibody binds on to the surface of the pathogen, binds onto the virus or the toxin or whatever it is, and then sort of covers up the pathogenic regions. Basically, it's masking the parts of that molecule that make it dangerous. The antibody is not destroying the pathogen, it is neutralizing. It is making it harmless. Once it's been rendered harmless, other immune mechanisms can kick in and deal with it. You might recall that I mentioned we have some cells whose specific job is to destroy antigen-antibody complexes. Remember that? We talked about antigen-antibody complexes. When an antibody binds to an antigen, that's exactly what we've just made. We've made an antigen-antibody complex. And you saw when we talked about our non-specific defenses that we have a variety of ways of dealing with those. Specifically, we're going to find that our antigen-antibody, sorry, hang on a second, can't get out of my way. But we're going to find that our antigen-antibody complexes are removed either by immune clearance. Remember, we talked about immune clearance as... All right, everybody, this is my teaching assistant, Eris. She's going to be helping with this component of the lesson. Okay? All right, so we're going to remove those antigen-antibody complexes either via immune clearance, meaning that they're going to be attached to a passing red blood cell and sent to the liver for destruction. Alternately, you might recall that when neutrophils create their killing zones, that neutrophils can break down antigen-antibody complexes that have formed. Or finally, they can be destroyed by eosinophils. One of the jobs of eosinophils is specifically to break down and destroy antigen-antibody complexes. So once that pathogen has been neutralized, there are several different ways we can get rid of it. Now, another possible way that we can do this, rather than by using an antigen-antibody complex, is going to be through a process. Okay, Eris? Good with this? All right. Okay. That we're going to go about this through a process called precipitation. In precipitation, the antibody is actually going to cause a bunch of antigen molecules to clump together. It's going to gather them together into a big clump, preventing them from spreading in the body. Once those antigen molecules have stuck together into a big clump, they're easier to grab for immune clearance. And that's the primary way they're going to be removed once they have precipitated. They're going to be removed via immune clearance. A similar mechanism that antibodies can use to fight, to deal with your pathogens, is going to be through agglutination. Agglutination is a little bit different because it's the only form of humoral immunity that specifically targets cellular pathogens, specifically protozoans and fungi. If you have a protozoan infection, like you have an amoeba, or if you have plasmodium, which causes malaria, or if you have a fungal infection, then the way that that's going to work is that your antigen-antibody complex is going to be a clumping mechanism. But here it's going to cause antibodies on the surface of those pathogenic cells to clump together. As a result, those cells become immobilized, they become unable to move around, unable to invade your tissues, and those clumps of pathogenic cells can then be directly attacked by non-specific defenses. They can be gone after by macrophages or by neutrophils or NK cells or any of the other non-specific defensive mechanisms we've talked about. Finally, we can also engage in fighting antigens with antibodies through a process called complement fixation. In complement fixation, in complement fixation, the antibody is going to bind to the surface of the antigen, and it's going to cause that antigen to... Do any of you have cats? You know how this works, right? Okay. All right, so, but then in complement fixation, we're going to find that the antibody binds to the antigen, and then it provides an additional binding site. It changes the shape of the antigen into one that complement proteins can attach to. Remember, we talked about complement proteins as part of our non-specific defenses. This is basically making it easier for complement proteins to deal with the pathogen. So we got 4 different ways that our antibodies can do this. We could use neutralization to just mask the harmful regions of the pathogen and make it harmless. They can use agglutination to make harmful protozoan or fungal cells clump together for non-specific defenses to go after them. You can use precipitation to cause non-cellular pathogens to clump together, whereafter they can be removed via immune clearance. Or finally, you can use complement fixation, whereby complement proteins will bind to the surface of the pathogen, with the help of the antibody. All of these are mechanisms by which what you can see here, the antibody isn't destroying the pathogen. In all of these cases, the antibody is rendering the pathogen harmless and making it easier for other defense mechanisms to come in and deal with it, making it easier for our non-specific defenses like neutrophils or macrophages to deal with it, making it easier for complement proteins to deal with it, making it easier for things like immune clearance to deal with it. So we've got a lot of different possible ways here. But what they all share in common is we're not really destroying the pathogen. We're tagging it for destruction by another mechanism. This whole time that we're talking about the action of the antibodies, let me remind you that in the background, the Th cells are still helping. They're still causing more plasma cells to form, which means that we're getting more and more antibodies to come after the threat. And they're still also, in the meantime, going to be causing non-specific defenses to come in. You might recall that Th cells are going to be attracting macrophages. They're going to be attracting neutrophils. They're going to be bringing in all these other cells you've already heard about, which will then help to clean up the pathogens that the antibodies have neutralized. Okay, feeling good about that? Give me just 1 second, folks. Got our first 2 steps done. We've got recognition, we have identified the pathogen, we have attack, during which the antibodies have been produced, they have attached themselves to the pathogen and neutralized it or clumped it together in a couple of different possible ways. Final step, same as with cellular immunity, is memory. Now, from the time that the initial pathogen exposure happens, from the time that your APCs recognize a pathogen, say, here's a problem, we need to find a way to deal with it, you're going to find that there's usually a gap of about 3 to 6 days from initial exposure while your body is training up plasma cells to deal with the threat. Once that happens, once you've got a family of plasma cells that know what to do, your antibody levels are going to slowly climb, and they're going to rise and rise, and what we call your antibody titer, that is the quantity of antibodies present in your bloodstream, is going to go up little by little. You'll find that for most pathogens, the antibody titer is going to rise and then drop within about a month. You know, that it will usually peak about 2 to 3 weeks after initial exposure. And then after about a month's time, it will begin to taper off. We call this the primary response. You know, this is the initial response to that pathogen. Now, presumably you've defeated the pathogen at this point. If your body has not successfully defeated the pathogen, well, we don't really have much to talk about because you're not here for that to be an issue anymore. But let's assume you've defeated the pathogen. Now, some of those B cells that we formed initially did not turn into plasma cells. Plasma cells die quickly. Plasma cells only last 4 to 5 days. But some of that population of B cells that formed initially is, instead of turning into plasma cells, going to transform into what we call memory B cells, or B subscript M cells. The memory B cells will take up residence in your thymus and your bone marrow, where, just like memory T cells, they are going to retain the ability to make that antibody again in the future. Should you be re-exposed to that same pathogen later, should you have a second exposure to that virus or whatever else is going on, then what you're going to have is going to be a so-called secondary response, also called an anamnestic response. And in the secondary or anamnestic response, the memory B cells recognize a pathogen they've seen before. They say, uh-oh, it's back. Fortunately, we know what to do. They don't have to go through that whole complicated process of learning how to make an antibody again. They already know. So in the secondary response, they will just begin rapidly cloning themselves, undergoing quick mitosis, and start to make lots of antibodies in a hurry. You will find that your antibody titer rises very sharply during the secondary response. Usually, as with the memory T cells, rises fast enough that you will defeat the pathogen before you even know that you are infected. Once the antibody titer rises during a secondary response, it will stay elevated for quite a while. In fact, If you've been exposed to a virus or another pathogen that your immune system already knows how to deal with, when you're re-exposed to it, the antibody titer will rise and it will stay elevated for months or even sometimes for a couple of years after that secondary exposure. Our immune systems go from the assumption, okay, this threat is present in your environment, we're going to stay ready for it, and therefore keep your antibody levels high after that secondary exposure for some time. In this way, you can get away with immunity to a pathogen once you survive it once. If you've been exposed to a given virus or given toxin repeatedly, then your body can build up a resistance. It can find a way to build an antibody against it and thereby be ready to defend against it. This applies to viruses, much more I should say than to toxins. A lot of toxic molecules will be broken down by your liver or will be passed out of your body via urination or sweats before you have a chance to build an antibody against them. So this is one of the reasons why it's harder to develop immunity to a toxin, simply because it has to stay in your system long enough to actually make an antibody without it actually killing you in the meantime. Repeated exposure to tiny doses of toxins will end up helping you to develop immunity against them. That's the main way that you can get resistance to a toxin. You probably all know that if you're exposed to a given drug enough times, your body begins to build up a tolerance for it. And that's really it getting better at processing what, as far as the body is concerned, is a toxin. Because if a molecule is not made by the body, your immune system is going to say, uh-oh, this doesn't belong to me. Now, this is a good time to remind you about vaccination. The entire point of vaccination is essentially to give your B cells a chance to learn how to make an antibody before you actually have to deal with the pathogen. That those B cells are being pre-exposed. When you get the vaccine, you're getting either a quote-unquote dead pathogen, or in the case of viruses, because they're not really alive in the first place, a chemically inactive form of the pathogen, one that is incapable of doing you harm. For some pathogens, the best we can do is what we call an attenuated pathogen, meaning that we can't quote-unquote kill the virus without it becoming unrecognizable to the immune system. But what we can do is significantly weaken it so that it doesn't make you sick when you get the vaccine. But the overwhelming majority of vaccinations are basically exposing you to quote-unquote killed viruses or other dead pathogens. Now, the pathogen may be harmless to you at this point, but your immune system can still respond to it and can still learn to build an antibody against it. So that's what the vaccination was really doing for you. The vaccination is letting your immune system have some training, that it can learn how to defeat that pathogen in advance. So that whenever you're exposed to that pathogen in the wild, like you've had your measles shot, you get exposed to measles in the wild somewhere, you have an anamnestic response. You begin producing antibodies rapidly without you having to have suffered through the measles in the meantime. We have found that for some viruses, particularly those that undergo mutations, that your body cannot always get full immunity with a single vaccine. Sometimes it takes multiple doses of the vaccine when you're young and when you're older, a so-called booster, in order to create a permanent secondary response that will kick in and defeat the pathogen whenever you are exposed to it in the wild. Several of the vaccines that hopefully you had as kids, vaccines against measles and whooping cough in particular, are things that we have now found benefit from a booster, to help make the immunity permanent. Some of you have also had your vaccines against hepatitis or a few other viruses where the vaccine has to be given in stages. That's basically a safety measure where we're giving your body a chance to develop parts of the immune response without putting you at risk from the pathogen in the meantime. Now, as with memory T cells, memory B cells can live in your body for years, decades, in general for the rest of your life. But we have found that over time, sometimes you can experience a decline in their functionality. So even a disease that you have technical immunity to from wild exposure, you might find later in life that you have something of a response to it, even if it's not as strong a response as you might have had when you were younger. Essentially, as you get older, your immune system is not as good as it used to be. You're not going to be able to produce T cells and B cells as rapidly. Your thymus has involuted, you have less red bone marrow, and as a result, all of your responses are going to slow down with age, even against things that you are immune to. So, by and large, this is permanent immunity, but it may not work as well when you're older, particularly if your immune system is already weakened or compromised in some fashion. So that's our 3 steps of humoral immunity. Recognition, we figure out what the pathogen is, we begin preparing B cells to deal with it. Attack phase, B cells develop an antibody against the pathogen, and they go after it via complement fixation, agglutination, neutralization, or precipitation. Thirdly, memory stage. Some of those initial cells become memory B cells, retain the knowledge of what to do, so that if you're re-exposed, you can have a rapid secondary response. All right, so these are our mechanisms of specific immunity, folks, and they are remarkably good at helping your body to deal with a wide variety of pathogens. In general, once you have been exposed to something that specific immunity has helped you to overcome, you don't have to worry about it again. Now, you might ask yourself, okay, well, why do I keep getting the common cold? Why do I keep getting the flu? That sort of thing. A couple of reasons for that. For starters, keep in mind that some pathogens, particularly RNA-based viruses, are going to mutate really, really quickly. Now, any given virus is either going to be an RNA virus or a DNA virus. And my RNA viruses, that is, they use RNA for their genetic code rather than DNA. RNA viruses mutate much more rapidly than DNA viruses. They develop new strains of the virus rather quickly. The flu and the common cold are both RNA-based viruses that mutate really, really fast, which means that technically you're still immune to whatever flus you have had previously. You're still immune to whatever flus you've already gotten vaccinated against, or whatever other colds you've previously had, except that the viruses that cause those things undergo fairly rapid mutation. As a result, the flu that's around this season is not genetically identical to the flu that was around last season. And therefore, the secondary response that you have from last year's flu might not do anything against this year's flu. In some cases, you will find that antibodies that are similar will have a partial response. Specific immunity is really picky. Specific immunity in general is this pathogen, this strain of this pathogen, only that one. But for something like the flu, where a lot of strains are genetically very similar to each other, you might find that partial resistance to one pathogen is going to give you a little bit of benefit against another. So I'm immune to last year's flu. It's not exactly the same as this year's flu, but it's close enough that my antibodies can provide some help against it. This is one of the benefits of getting a flu shot every single year, by the way, that you're exposing your body to more and more possible combinations of flu genes over time. And that means that you have a greater chance that some B cells in your immune system will understand a combination of genes to help you overcome any given new flu. Another thing to consider about why we get certain diseases again and again is that they're not always caused by the same viruses. That keep in mind, we tend to identify a disease that you have on the basis of a constellation of symptoms you get. We say, okay, I've got, a stuffy nose, a headache, I'm feeling weak, I'm coughing, I have a sore throat. This all sounds like I've got the common cold, right? Well, that constellation of symptoms can be caused by several different viruses. There are more than 200 different viruses that can cause the thing that we call the common cold. Some of them are called adenoviruses. Some of them are called rhinoviruses. The coronavirus that you're hearing so much about, there are actually several types of coronaviruses. You've probably had some coronaviruses in your lifetime that have caused you to get colds. So whenever you start showing the symptoms of a cold, there's no way of knowing it without doing a very specific viral test what exact virus is causing that constellation of symptoms. So even though you are personally immune to every different viral cold you have had in the past, when you get another cold, that just means it's a different strain of the virus or a different virus causing similar symptoms that you have personally never been exposed to. All right, sounding good? All right, so you've heard about cellular immunity. You've heard about humoral immunity. You've learned how our bodies build specific defenses against a wide variety of threats. But let's talk now about what can go wrong. Our immune systems are not perfect. Our immune systems can fail in a wide variety of ways. As you've all seen, people die from infections, from viruses, from pathogens, from toxins of different kinds, And this is precisely because our immune systems don't always win the race, that the T cells don't always kill off the dangerous bacteria or cancer cells before they can do you harm, that the B cells don't always come up with the right antibody in time to stop the virus. So anytime you get any kind of pathogen, your body is rushing to find a solution before the pathogen can do you irreparable damage. And sometimes we don't win that race. More often than not, we do. While you have been listening to this lecture, you have been exposed to billions, if not trillions, of bacteria, viruses, and other pathogens in your environment. And your immune system is going to overcome most, if not all of them. It's pretty good at its job. The first line of defense blocks the overwhelming majority of those pathogens from getting into your body in the first place. Second line of defense mechanisms like macrophages are going to shut down most of the ones that do manage to get in. And as you've seen, specific immunity, whether humoral or cellular, is pretty darn good at catching the other ones. We can't always succeed. Sometimes immune defenses fail because the body is not able to mount an effective defense. Sometimes you are, as we put it, immunocompromised. And when an individual is immunocompromised, that means their body is not able to mount as good an immune defense. The immune system is weakened. This can happen for a variety of reasons. Most easily is the fact that whenever your body has already been stressed, it's not going to have the resources to fight back as well, that it's not going to be able to as effectively bounce back against a threat. You're fighting another infection. You're injured. You've lost blood due to an injury recently. You're stressed. All of these things demand energy and resources, and as a result, they can mean that your immune system does not respond as well to a given threat. You might be malnourished. Keep in mind that your immune system requires a lot of resources to do its job, that you need a steady supply of amino acids and various vitamins and minerals in order to effectively build plasma cells, to build antibodies, to build T cells, and so forth. If you're not getting the nutrients you require, if you're malnourished or undernourished, your body quite simply doesn't have the resources to spare. And as a result, you may not be able to mount as effective a defense. We all become a little bit immunocompromised as we age. When you're getting older, your thymus is shrinking, you have less and less red marrow. And that means you have less tissue capable of making your various lymphocytes. So as we get older, all of us become more susceptible to all sorts of pathogens. We get them more easily, and we recover from them more slowly. So you can see there are a bunch of possible reasons why at any given moment your immune system may not be able to mount as effective an attack against the pathogen as it can in other times. All of this is normal. It is completely normal for us all to have moments when our immune systems are not functioning as well as they otherwise could, when we're fighting another threat, whenever we're injured, when we're stressed, when we're simply aging. But we also have to talk about immune disorders. And to finish out this chapter, I'd like to talk to you for a few minutes here about things that can go wrong with the immune system, about ways in which our immune systems do not always work the way they should. Not just because they're starved of resources, not just because you're stressed or tired or dealing with another threat, but because something is actively wrong with the immune system itself. Oh, a thing I did not mention there in passing that's really worth bringing up, and that I'm sure that you've all noticed, is that when you're tired, when you have not rested sufficiently, when you're getting poor sleep, when you've not given your body a chance to recharge, it's not as good at defending itself. there is something to the idea that rest is good for overall health. And if you're not giving your body sufficient chances to take a break and recharge, you're going to erode your immune defenses. If you are sleeping poorly, or if you're just on the go all the time without pausing from time to time to rest and recuperate a little bit, it's going to be harder to keep your immune system up to snuff. So there is some merit to just resting from time to time in order to make sure your immune system has the energy that it needs to do its job. You also know that exercise is a factor here. I mentioned earlier this semester that if you are exercising, you are stimulating your lymphatic system, you're circulating fluids more, you're moving fluid into the lymph nodes more effectively. You're basically giving your body more opportunities to filter lymph with its like basic initial and secondary lines of defense, and to expose T and B cells in the lymph nodes to novel pathogens, thereby allowing them to mount a response. So there's a direct correlation between regular exercise and immune health. But back on topic. Let's talk about immune disorders. Now, fundamentally, immune disorders fall into two broad categories. We can talk about there being hypersensitivity disorders. Actually, three broad categories. We've got hypersensitivity disorders, we have autoimmune disorders, and we have immunodeficiency disorders. Nothing I've talked about thus far here has been a disorder. This has all been things that can happen naturally in the course of your body's normal activities, in the course of its normal responses to the things happening in the world around you. But let's look at the ways in which this can fail. Start with hypersensitivity. A hypersensitivity disorder is any situation in which the immune system is overreacting, in which the immune defenses themselves are becoming a problem. Essentially, the immune system is having an overinflated response to a pathogen that is not actually a problem. In this case, the immune system is drawing resources away from other bodily systems, and it's creating dangerous chemicals like the killing zones of neutrophils, or it's creating a variety of responses like fever and inflammation and so forth in times when they're not needed. So basically, the immune system can become an enemy if it overreacts. Now, most of us are going to have basic immune responses to a few things in our environments. You know, there are things that are pathogenic to everybody. There are things that are pathogenic to some people and not to others. If all's going well, your body is tolerant of its own antigens. Self-tolerance is one of the basic immune functions. When you're talking about a threat that comes from outside, that is known as alloimmunity, A-L-L-O. Alloimmunity is going to basically be a response to anything that comes from outside of you. There are four basic types of hypersensitivity responses. Type 1 is the one you're probably most familiar with. That is called acute hypersensitivity. In acute hypersensitivity, your body is having a response to an antigen that wouldn't be a problem for most people. We talked a little bit earlier today about why that can happen, that there are some molecules which are too small to activate the immune defenses by themselves. We call those haptens. But if that hapten binds onto another antigen, it can change the shape of that antigen, and sometimes that means your immune system will look at an antigen it normally tolerates, say, uh-oh, that thing is bad, and you'll have this overblown response to something that most people have no problem with. That's a type 1 or hypersensitivity response. It usually begins really quickly. Acute hypersensitivity responses normally begin within seconds or at most a couple minutes of exposure. Normally, they're going to begin to subside within about 30 minutes, but if you have ongoing exposure, the response can continue. Most of our common allergies are type 1 or hypersensitivity responses. What happens in a hypersensitivity response is that our allergens, that is our antigens that set off an allergic response, usually because they have haptens attached to them, are going to bind onto basophils and mast cells. You might remember those from a while back. We haven't talked about them in a while. Basophils and mast cells are other types of white blood cells. Basophils and mast cells, you might recall, are going to stimulate inflammation. They're going to stimulate vasodilation. They're going to cause increased capillary permeability. And they're going to cause smooth muscle spasms. These are all responses we tend to get from allergen exposure. Now let's think about what these things actually mean for us. That if we have vasodilation, more blood flow is coming into the affected area, the affected membranes where the allergen is found. More blood flow is going to mean localized edema, which means you can get swelling or hives at the site of the allergen. It can also put pressure on nerves, causing an irritation response that can lead to itching or pain. All the things that come with your inflammation, right? Redness, pain, heat, and pardon me, folks, I'm having a little bit of asthma. We're going to talk about asthma in just a minute. But our redness, our pain, our heat, and our swelling, all of these things can happen with your allergic responses, right? You get inflammation at the site of the allergy. We can also get localized edema, which causes hives or swelling in that area. Increased capillary permeability means more fluid accumulating in the site. That's why you can get, say, a runny nose from your allergies. The really interesting one is the smooth muscle spasms, that a lot of times you'll get smooth muscle spasms at the site of allergic exposure. If those become severe enough, if you have very severe smooth muscle spasms, you can experience a response that I've mentioned in here before, anaphylaxis. A-N-A-P-H-Y-L-A-X-I-S, anaphylaxis. Anaphylaxis is a very rapid and very extreme allergic reaction. And it can be extremely dangerous because anaphylaxis can cause your throat to close up. It can cause your bronchioles to close up in your lungs. It can cut off airflow. It can cause circulation to become depressed. You can go into anaphylactic shock, and circulatory shock from anaphylaxis can be lethal. The countermeasure to this, your standard anti-allergy medications are not going to help if you go into anaphylaxis. We need to overcome that systemic vasodilation that is causing you to lose blood pressure and lose consciousness and possibly to die. The way we do that, systemic vasoconstriction. And the best way to do that is with adrenaline hormones. You know, the EpiPens that people have for severe allergic responses like bee stings and so forth. What's going on there is we are giving you a shot of adrenaline hormones. We are stimulating your body to begin counteracting the responses of anaphylaxis, to induce vasodilation, constriction of blood vessels system-wide, as opposed to vasoconstriction, the widening of those vessels. If we administer that quickly, we can shut down the anaphylactic response. Now, most of the time, your allergies are not going to lead to an anaphylactic response. Anybody here who has an allergy knows what kind of things you can get. You're going to break out in hives or rashes. You're going to have runny eyes. You're going to have a runny nose. You're going to have a scratchy throat. All of these things can come with your allergies. You can end up with mucus hypersecretion, congestion. Sometimes you'll end up with cramps or diarrhea or vomiting, especially if it's a food allergy. Now, not all allergies are a type 1 response. A couple of allergic responses happen via one of the other mechanisms. Your food allergies are usually type 1 responses. Your seasonal allergies, your allergies to pollen or mold or hay fever, those kind of responses are usually going to be type 1 responses. For the most part, you can deal with them with things like anti-inflammatory drugs or antihistamines to cut the congestion. Now, there's one type 1 response that bears some special attention, and that's a condition that I have and that many of you in this room might have as well, known as asthma. A-S-T-H-M-A, asthma. Asthma is a kind of hypersensitivity response in which the lungs experience bronchioconstriction or bronchoconstriction, meaning that the bronchi, the airways in the lungs, begin to clench up in response to a variety of stimuli. Asthma is a highly variable condition. The stimuli that set it off for one person will not necessarily set it off for another. In general, asthma is a response to irritation of the lungs. A lot of times, that's one of the things that cause other allergic responses. If you have hay fever or other seasonal allergies, you will find that they will often activate asthma responses as well. But some asthmatics are going to be responsive to other stimuli. Some people get asthmatic symptoms in response to emotional stress. Some people get asthmatic symptoms in response to changes in environmental temperatures, particularly sudden changes in weather or very cold temperatures. There is exercise-induced asthma, in which asthmatic symptoms happen whenever you've been exercising lots. Or you could be like me and get all the above. Now, the stimuli that set off any given asthmatic are highly variable, but the symptoms are basically the same. You're going to experience constriction of the airways in the lungs. That's going to be the primary hypersensitivity response. As a result, breathing becomes harder and more labored. You experience the characteristic wheezing symptom, that sort of raspy breath. You'll find that there's often mucus hypersecretion that goes with asthma problems, both in the nasal passages and in the lungs, which leads to coughing up mucus and so forth. A severe asthma attack, that is a strong episode of bronchoconstriction, can lead to great difficulty breathing and potentially impaired cardiac function if you're not getting sufficient oxygenation coming in. It is technically possible to die from an asthma attack. My great-grandfather did, although that would be a rather extreme response. Either way, asthma is a type 1 condition. The way we deal with asthma primarily is with the help of tools like these. The primary way of treating asthma symptoms is with inhaled steroids. Corticosteroids are the primary tool that we use for fighting asthma. I'm holding up two different kinds of corticosteroid inhalers right here, and there are a wide variety of types. Some types work better for different asthmatics than others, and there are a few non-steroidal inhalers available. This one that I'm holding up right here, a lot of you in clinical settings will see this one. Many of you might have used an inhaler like this at some point. Sometimes they're prescribed short-term for conditions like bronchitis, which simulate asthma without actually being asthma. This is albuterol, or albuterol sulfide, marketed under the trade name Ventolin. It's the most common quote-unquote rescue inhaler for asthmatics, where when I'm having my asthma trouble, I'm going to shake this thing up. I'm going to take a puff or two, inhale it into my lungs. There we go. I had asthma symptoms today just for you guys. That's how much I love you. But that corticosteroid that's getting into my lungs is having an anti-inflammatory effect. It's counteracting the effects of the environmental stimulus that is causing me to have asthma symptoms. A lot of asthmatics will take long-term inhalers. This is Symbicort. It's a common one that's used not only for asthma, but for treatment of lung cancer patients. That these will help reduce the likelihood of asthmatic attacks from happening. I'm talking about asthma in this chapter. You might have expected it to be in the respiratory system chapter, because ultimately asthma is an immune response. It's a hypersensitivity response in the immune system. And so this seemed like the appropriate place to put it. All right, so that's type 1 responses, allergies and asthma. Your type 2 hypersensitivities are sometimes called antibody-dependent cytotoxic hypersensitivities. Type 2 is really a more common way of putting it. We're going to find that these happen whenever antibodies attack surface antigens, leading to the lysis or opsonization, the buttering up, of cells that otherwise would not demand an immune response. Type 2 hypersensitivities basically cause the body to identify something that is actually doing good stuff for you as bad. It's not quite the same as autoimmunity. because it's a response to a cellular agent in your body that's actually doing you good. The most common reactions here are transfusion reactions and tissue rejection. So whenever you have a tissue graft that your body is rejecting, when you have a transplanted organ that your body is rejecting, or if you get the wrong type of blood in a blood transfusion, for example, you get type A blood when your blood type is B, that is going to be a type 2 hypersensitivity response. So that is going to be what happens then in our rejection responses. Now, some drug reactions also cause a type 2 response. This will occur whenever you get antibodies to bind onto a surface cell and inhibit its function. There's a condition called myasthenia gravis. This is a muscular condition in which antibodies bind onto muscle cells and inhibit their actions. Patients with myasthenia gravis will have episodes of slack and poorly responsive muscles. Their faces will look very, very droopy. Their eyelids will droop. They'll look like they're very, very tired even when they're not, because they're having a hard time making their muscles respond because antibodies are binding on to the surface receptors on the muscle tissue itself. Sometimes a type 2 hypersensitivity will lead to the overstimulation of certain tissues. The most well-known example of this is when the antibodies will bind on to the thyroid gland and overstimulate it. That causes a phenomenon called toxic goiter. You might have heard of that. Toxic goiter is basically a type 2 hypersensitivity response hitting the thyroid gland, causes the thyroid gland to hypertrophy, to swell up considerably, leading to large swollen areas in the throat. This can happen as a result of a type 2 hypersensitivity, or it can happen as a result of an iodine deficiency. Next up, we have our type 3 hypersensitivities. Those are known as immune complex hypersensitivities. In type 3 hypersensitivities, antigen-antibody complexes, instead of being removed via immune clearance, end up getting precipitated beneath endothelial membranes. They become trapped underneath the endothelia of your blood vessels. As a result, you're going to end up with considerable immune activity in your body's connective tissues. This will lead to intense inflammation of connective tissues, the activation of complement proteins in your body's areolar tissue, and that can lead to significant tissue destruction. We find that type 3 responses most commonly happen in autoimmune diseases. The best known example of this is a condition known as lupus erythematosus, better known simply as lupus. Lupus results in systemic connective tissue inflammation. Your connective tissues all over the body, primarily areolar tissue, become badly inflamed. This will result in, among other things, persistent fever, constant fatigue, joint pain, sensitivity to the skin, rashes, sensitivity to bright lights, the formation of skin lesions from hypersensitivity of the skin, and in extreme cases to weight loss and eventually to kidney failure. Lupus seems to be autoimmune in nature. We do not know why it happens, but the response you're getting from lupus is technically a type 3 hypersensitivity, where you're getting antigen-antibody complexes in your body's own connective tissue, and as a result, your immune defenses end up attacking your connective tissues. Finally, for our hypersensitivities, we have type 4 hypersensitivity, which is known as delayed hypersensitivity. In type 4 hypersensitivity, what's going to happen is that APCs will display your antigen, your allergen, I should say, to my T cells. This does not initially cause an allergic reaction. T cells take a little bit longer to respond, you might recall. As a result, you're going to end up getting the T cell reaction between 12 and 72 hours after allergen exposure. So in a type 4 hypersensitivity, you get a delayed response. You're exposed to the allergen or the pathogen, and then anywhere between half a day and 3 days later, then you will begin experiencing allergic responses. Most common examples of this, graft rejection. If you get a skin graft and your body rejects that, that's typically a type 4 hypersensitivity. Cosmetic allergies. If any of you find you're allergic to makeup of any kind, usually you don't respond the moment you put it on your face. It takes a little bit of time. That's a type 4 hypersensitivity. If you are allergic to metals, if any of you have found that certain metals, like with earrings or whatever, cause an allergic response in you, that's type 4 hypersensitivity. Some of the very well-known examples of type 4 hypersensitivities. The attack on your body's beta cells that happens during type 1 diabetes is a type 4 hypersensitivity. Type 1 diabetes, you might recall, does not happen right away. It has an onset sometime usually in late childhood. We call it juvenile diabetes for that reason, although it doesn't hit some patients until their late 20s. Now, this is a delayed reaction whereby your body knows its own pancreatic beta cells, but they don't get attacked until months or years into your life. And then as a result, you end up with this hypersensitivity response in which your body attacks its own pancreatic beta cells until you can't make insulin anymore. But probably the most well-known example of a type 4 hypersensitivity, and one that many of you have probably had, is the response to poison ivy. Poison ivy, poison oak, poison sumac, all of those plants that cause a delayed response in you, where you'll be out in your yard doing gardening, you'll get exposed to poison ivy, the oils touch your skin, and then a day or two later, that's when you get the response. That is a type 4 hypersensitivity. All right, so those are our hypersensitivity disorders. They're basically overblown reactions that the immune system is doing something more than we want it to do. Now, you might have noticed that several of those, there's some overlap here with what we call autoimmunity. Autoimmunity is any situation in which your body is attacking its own tissues. And as you've seen, a lot of hypersensitivities are autoimmune responses. Most commonly, what you're getting here is a failure of self-tolerance, that for whatever reason, your body is not properly recognizing its own immune cells. This leads to the production of so-called autoantibodies, that is, antibodies against your own tissue. You will find that most autoimmune conditions happen episodically. You'll get a flare-up for a little while, and then it'll diminish after a while as your antibody titer begins to drop. We do not know why autoimmune conditions will cause a short-term reaction that goes away and then flares up again later. The answer for that is really not clear. Why does this happen? A couple of reasons this can happen. Sometimes this will happen because an antibody against foreign matter will also cause damage to your body's tissues. Sometimes the antibody against something that's actually bad will incidentally harm healthy tissues at the same time. Classic example is there is a disease that hopefully you got a vaccine against when you were a kid called rheumatic fever. In rheumatic fever, the antibody against that disease also causes damage to your heart muscle. And therefore, people who get rheumatic fever have to worry about damage to the heart as well, because the antibody that's protecting against the pathogen also causes damage to cardiocytes. You can also end up with autoimmunity as a result of abnormal exposure of self-antigens to your bloodstream. You might recall that I pointed out that there is a blood-thymus barrier that prevents the bloodstream from coming into contact with your T cells while they are becoming immunocompetent. If that barrier breaks down for any reason, then you can end up with a situation in which your T cells are prematurely exposed to your body's own antigens. And as a result, they say, uh-oh, these antigens are bad, and the T cells begin to attack you. A specialized case of this involves the breakdown of the blood-testis barrier, T-E-S-T-I-S. That is the barrier between the bloodstream and the testicles in males. That can result in a situation in which you have an autoimmune attack on the man's own sperm cells. And if that happens, the man is often sterilized. This can be a secondary effect of several other diseases. Measles, notably, can result in sterilization because it causes a breakdown of the blood-testis barrier, and as a result, you begin attacking your own sperm. We think that a few viruses might result in autoimmunity. It is believed that certain diseases may be the result of a virus that causes an autoimmune attack. There's some evidence suggesting that type 1 diabetes is the consequence of a virus that most people are resistant to, but in a small percentage of the population, that virus will cause an autoimmune attack in you that destroys your pancreatic beta cells. I wish I could tell you more about autoimmunity, but the simple fact of the matter is I can't. Autoimmunity is a very mysterious phenomenon. I've named several autoimmune conditions for you here, but we don't really know a lot about why they happen, particularly in conditions like lupus. It is really, really not clear why autoimmunity is a thing. But let's now talk about immunodeficiency disorders. And in some ways, these are the scary ones, because immunodeficiency disorders are conditions in which the immune system itself is crippled. The immune system is not able to mount an effective response against a pathogen. Now, let's not confuse immunodeficiency with being immunocompromised. They're the same thing in terms of, if you're immunodeficient, you're immunocompromised, but not everybody who is immunocompromised is immunodeficient. We all end up with episodes of being immunocompromised because we're malnourished, because our bodies are busy fighting another pathogen, because we're super stressed. These are all things that happen. Immunodeficiency is a persistent failure of the immune system to effectively respond to pathogens. There are not a lot of immunodeficiency disorders, folks, for the very simple reason that most of the time, if you end up with an immunodeficiency disorder, you don't last long. If your immune system is not able to effectively protect you from pathogens, that means you're not able to mount a third line of defense response. That if the pathogen gets past your first two lines of defense, you don't have any effective way of dealing with it. And therefore, immunodeficiency disorders tend to be pretty lethal pretty quickly. There are two well-known immunodeficiency disorders. The first one is a condition called severe combined immunodeficiency disease, also known as SCID, S-C-I-D. We often use that abbreviation for it. SCID is a genetic disorder. It's an inherited recessive condition. The effect of SCID is that it causes a highly reduced level of T and B cells, or it causes them to be absent altogether. In other words, children born with SCID never develop an immune system proper. They never develop a third line of defense. As a result, they are highly vulnerable to both bacterial and viral pathogens. Kids with SCID, unless they are carefully protected, will die very quickly. Essentially, the only hope for a child with that disease is to live in a very sterile environment, a hyper-sterilized environment. They cannot freely roam the world at large because ordinary pathogens that you and I are exposed to every single day can easily be lethal to them. So most kids with SCID spend their lives in highly enclosed environments. They'll stay in hyper-sterile rooms. They will only leave those areas in spacesuit or bubble-like enclosed environments that protect them from environmental pathogens. Some of you might have heard the story of the so-called Bubble Boy, a young boy in the 1980s who there was a movie made about his life and everything, that he had SCID, and they developed a spacesuit-like tool that he could use to go out into the world at large, allowing him to roam around in the environment for the first time in his life. Sadly, he was eventually exposed to environmental pathogens and he did die. Most kids with SCID will eventually die because of an accidental pathogen exposure. Now, fortunately, SCID is one of the only conditions that right now gene therapy is effective against. Gene therapy is a very new technology, and the idea behind gene therapy is that we are essentially putting into your body a gene that it otherwise lacks, introducing a gene into your system that your cells don't possess. This is a way of counteracting a genetic disorder in which you're lacking a functional gene. Gene therapy is a tricky thing to make work because first off, it requires that whatever the problem is be monogenetic. That is, there's one gene responsible for the problem, which if we give you the healthy version of that gene, your body will be okay. And a lot of pathogens, or no, it's not pathogens, a lot of diseases that we have are not monogenic. They require more than one gene for you to end up with that genetic disorder. The other reason this is difficult is because we have to find a way somehow to get that novel gene into every single cell of your body. The primary way of doing gene therapy to date has been to use a virus to do it, actually to use a common cold virus that has had the harmful cold genes removed from it and had the genes that your body is lacking spliced into it. And what we do is we affect you with that cold virus. It spreads through your system like any virus would, and therefore deposits that gene in your cells. The problem and the limitation in gene therapy that has made this harder to deal with is that your immune system eventually recognizes the virus and kills it, even though it's delivering a positive and healthy gene to you. But we can take advantage of that with SCID, because in a patient with SCID, there is no immune system to stop that virus. So what we can do is we can insert the gene that kids with SCID are lacking into a virus, infect them with that virus. It spreads throughout their body because they have no immune system to stop it. It infects every cell of their body, or nearly every cell. But once that virus is inside their cells, that gene is now part of them. And therefore, their bodies can begin to develop an immune system. So at this point in time, SCID is the only unambiguously successful form of gene therapy. It is the only condition that we have been able to cure with gene therapy. And as a result, kids with SCID now have a chance because we can use this therapeutic on them. Assuming that is, of course, that we can get it to them before they are killed by some other environmental pathogen. Now, the big one. We can't talk about the immune system without talking about HIV. Now, as we said in class the other day, HIV is not the same thing as AIDS. HIV is a virus. AIDS is the syndrome resultant from that virus. HIV stands for human immunodeficiency virus. As I said in class, it is descended from a chimpanzee virus called SIV, simian immunodeficiency virus. The word simian means ape-like or monkey-like. It's believed that it made the jump into human populations in the 1920s or 1930s, whenever someone was butchering a chimpanzee and was exposed to the pathogen in its blood. Now, the HIV virus, human immunodeficiency virus, is a nasty customer because of how it attacks the body. Two reasons why it's especially bad. Well, three reasons. I told them two things, three reasons. One, because HIV is a rare example of what is called a retrovirus. A retrovirus is an RNA-based virus, which once it enters your cells, begins to assemble new DNA. It assembles viral genes which stay in your cells in the form of new DNA. That makes it very hard to get rid of. Furthermore, RNA viruses mutate considerably faster than DNA viruses, which makes HIV a really hard virus to keep up with. There are more than 200 known strains of HIV, which has greatly frustrated efforts to build a vaccine. Secondly, HIV is a particularly tough customer because of the long latency period of the virus. HIV, as I indicated in class, has a latency period of up to 10 years, meaning that it can sit dormant in your body for a very long period of time. And that whole time, you can be infecting people with it. You don't know it's there. And as a result, you can be exposing others to it, sometimes for years. Scary statistic. It is estimated that 1 in 4 people with HIV do not know they have. But the real reason that HIV is a particularly difficult virus for our bodies to defeat is how it attacks you. HIV specifically attacks immune cells. HIV invades dendritic cells, which you might remember are one of our primary macrophages and APCs. HIV invades macrophages themselves. HIV invades TH cells, T helper cells. It strikes, in other words, at the cells that coordinate your body's immune responses and that are responsible for your all-important second line of defense. As a result, the virus, from the time it infects you, begins eroding your body's ability to combat other pathogens. It can sit dormant in your body for 8 years, 10 years, 12 years, or it might affect you very quickly. Some people, upon exposure, will begin showing symptoms of HIV within a few months. Some will be a long, long time. Initially, when HIV becomes active, you're going to get flu-like symptoms, aches, fevers, chills, and those symptoms are going to become more and more pronounced as more and more of your T cells are destroyed. Now, normal immune function requires a TH cell count of 600 to 1200 TH cells per microliter of blood. As HIV continues affecting your system, your levels of TH cells drop and drop and drop. Once your levels of TH cells have fallen to 200 TH cells or less per microliter of blood, at that point your immune system is effectively unable to fight back against most pathogens. At that point, we say that you have acquired immunodeficiency syndrome, otherwise known as AIDS. So AIDS is a syndrome caused by the HIV virus once it erodes your immune system to a certain point. Once AIDS has set in, your body is not able to fight off a very wide range of pathogens. You begin to become sick very, very easily, and you begin getting sick with things that most people do not get. Adults will get conditions like thrush that are mostly only found in young children, or you will begin suffering from very minor infections or minor viruses that most people would never know they had because their immune systems would shut them down right away. Or very commonly, you will begin getting strange cancers, exotic cancers like Kaposi's sarcoma that most people's bodies shut down before you ever know you have them. If I didn't mention this earlier in this chapter, folks, it's worth knowing. Cancer is pretty common. You've all had cancer. You've all had cancer this week. And your body usually shuts it down before you know about it because NK cells are really, really good at getting it. But without TH cells, you're not making interferons properly, and your NK cells and your neutrophils and your macrophages don't know what to go after. And your macrophages aren't as effective to begin with. So nobody dies of HIV. What you die from is the other things your body couldn't fight off anymore. You die from cancer, you die from viruses, you die from bacteria. That's what's ultimately going to kill you. Now, let's talk about transmission, because there is a lot of mythology about this. Let's make it understood. You can't get HIV from kissing somebody. You can't get HIV from sharing a fork or drinking from the same glass or the same water fountain as somebody. You don't get HIV from a toilet seat. HIV dies really quickly on surfaces. It's easily killed by soap, bleach, chlorine. It does not survive well outside of the human body. The way you get HIV is by direct fluid transmission, direct exposure of your bloodstream or your body to the blood, the semen, the vaginal secretions, or the breast milk of an infected individual. Those are the primary ways this happens. In the early days of HIV infection, before we knew this was a danger, a number of people got infected as a result of blood transfusions. Now it has become routine that anytime blood is donated, every pint of donated blood is tested for HIV before it's made available to someone. There hasn't been somebody accidentally infected with HIV via a blood transfusion in the United States since the early 1990s. So it's not a thing we really have to worry about anymore. We've taken measures to lock down the blood supply. So how do you personally get it? You get HIV typically from unprotected sex with an individual who is infected by exposure to their semen or their vaginal secretions. You get it from mother-to-child transmission via breast milk, or you get it from blood sharing, not via transfusion because we have protection against that, which almost always means sharing of needles. Intravenous drug users, people who are using heroin or other injected drugs, and share needles with other users very often will end up passing viruses that are bloodborne along with it. And so there's a lot of HIV transmission that happens among drug users who are in the habit of sharing needles with one another. I should let you know right now, there is a common misperception that HIV is a disease that affects homosexuals differentially. And it is true that the disease was first detected in gay populations in San Francisco, New York, and New Orleans. But there's nothing about being gay that makes you more likely to have or get HIV. It's a disease that was identified in the 1980s. They called it the gay cancer. It's not a cancer, and it's kind of a not really good way of describing it, because there is nothing about being attracted to the opposite sex that makes you less likely to get it. Here's a fun statistic for you that you may not know. 75% of HIV infections happen as a result of unprotected heterosexual vaginal intercourse. In other words, the majority of people who have HIV are people who are having sex with people of the opposite sex, and they are having vaginal intercourse, and they are transmitting the virus that way. HIV has long been a problem in the gay community, in large part due to the fact that while homosexuality was much more heavily stigmatized in the 1980s and 1990s than it is today, I mean, not that I'm saying there's no stigma now, but when it was much worse than it is now, the gay community had a hard time getting supportive services, had a hard time getting care. There was a lot of underground cultures associated with the gay community, and a lot of health risks associated with surreptitious nature of gay relationships at a time whenever there was very serious social stigma associated with them. As a result, a lot of folks weren't taking precautionary measures, and the condition spread in the gay community much more rapidly than it might have otherwise. Today, of course, there's a lot more awareness, but the majority of HIV infections now are being transmitted by people who are not gay. So do not say, okay, that person is gay, they're more likely to have HIV. No, they're not. No, they're not. That is prejudice talking, and we need to get past that stigma. If you get exposed to HIV, what can we do? Well, the answers are actually better than they used to be. There's a drug called PrEP now, P-R-E-P, you might have heard about it, which can actually prevent HIV from taking hold in your body. If PrEP is taken prior to exposure, it can actually block HIV infections. I do not remember what the time frame on PrEP is. I don't remember how much protection it provides you ahead of time, but judicious use of PrEP can prevent you from getting infected in the first place. If you are exposed, well, there are some things that we can do now. We do not have a vaccine against HIV at the moment. It's a very difficult condition to vaccinate against because by its very nature, it attacks the immune system. There are several possible HIV vaccines in the pipeline. There are some very promising potential ones being tested right now. But at the moment, we do not have a single effective HIV vaccine. We're working on it. We hopefully will get there within the next decade, but we are not there yet. What we do have right now are so-called antiretroviral drugs. It's a cocktail of a variety of different drugs, which, if taken regularly, can slow the spread of the virus within the body. It does not cure it, does not take the virus out of the body, but what it can do is prevent it from spreading and slow the rate at which it destroys your immune system. Antiretrovirals can effectively manage the condition now, and people who have been exposed to HIV with the help of antiretroviral drugs can live 20, 30 years with the virus. There are some very promising new treatments that have been tried out in recent years. Some of you have probably heard that within the past 2 years, we have actually cured a few people of HIV. And the way that was done was by giving these individuals transplants of bone marrow taken from an individual who is naturally immune to the virus. We have discovered that a tiny percentage of the population is genetically immune to HIV. And so whenever those individuals have been found, a bone marrow transplant from someone who has that immunity put into the body of an HIV patient allows that individual to make T cells and B cells that are not affected by the virus. As a result, their normal immune defenses can kick in and develop an antibody against HIV. So for these rare few individuals, we have actually been able to cure the virus. It requires a very rare convergence of circumstances. We have to find a bone marrow donor that has that resistance, and they have to be compatible with the bone marrow receiver in the HIV patient. To date, if I'm remembering properly, 3 people have been cured in this way. But it is pointing the way towards possible therapeutics that we might be able to leverage in the future. So HIV is still a danger. You don't want HIV. It's easy to avoid exposure. Practice safe sex. Use barriers. Make sure that you're taking appropriate precautions, that you're having appropriate discussions with partners about risks. Don't share needles. You shouldn't be using needle-injected drugs anyway. That's probably not a good idea regardless. But if you take those measures, then you can probably avoid it. We don't have a cure yet, but we have a lot more ways of managing the condition than we used to, and we have some very promising possible future therapeutics. But at the moment, it's probably our single most pervasive and most dangerous immunodeficiency condition. So that is where we are at. That brings us to the end of our chapter on lymphatic and immune systems. Hopefully this is a benefit to you to have this lecture where you can go back and listen to it at will and go back over things. If you have not already done so, please check the notes that I have posted on Blackboard going along with this lesson so that you can follow along, get the terminology, the spelling of the words that I've used, and so forth. And whenever I get back to class next week, I'll take any questions that you have about this at the time. I am also going to be posting to Blackboard in the near future. By the time you see this, it might already be up. An assignment on the immune system. You've already taken your quiz on the lymphatic system. I'm going to provide an immune system assignment for you, specifically dealing with the mechanisms we've just discussed for specific immunity. Everything starting with, the difference between cellular and humoral immunity and the different ways of acquiring immunity, up through the things in this lesson will potentially be covered by that assignment. All right, thanks for your time, folks. I will see you on Tuesday of next week. Have a good evening.